Thank you for joining us for today's webinar titled Consideration of Non-Motor Symptoms in the Successful Delivery of LSVT Loud and LSVT Big. We're delighted to have you in attendance today. My name is Beth Marcoux, and I'll be moderating today's session and presenting the first half along with my colleague Angela Halpern. Before we get started, I'd just like to go over a few of the logistics. In terms of logistics, right now, everyone in the audience is automatically muted, so there's no background noise from the various environments where you may be joining us. But there are a few ways that you can ask questions at the end of the webinar, including the question and answer period. First, you can type your question. You can type the question in the question box on your control panel. I'll then read your questions aloud to the group, and one of the presenters will respond. Second, you can raise your hand. You can raise your hand by clicking on the hand icon on your control panel. I'll then see that you have a question. I'll unmute your microphone and call out your first and last name to let you know the microphone has been unmuted. You can then ask your question aloud to the group and one of the presenters will respond. The third way you can ask a question is to email us. If we run out of time for questions today, or if you think of a question after the webinar, you can email us with it at any time. I'll display this email address at the end of the presentation. The email address is info, as in information, at lsvtglobal.com. This afternoon, what we will be doing is presenting considerations of the non-motor symptoms of Parkinson's disease. I'll present the first part talking about those non-motor symptoms, and Angela will take it halfway and discuss the LSVT Big and LSVT Loud treatments. This afternoon, we have myself, Beth Marcoux, and Angela Halpern. Angela is a speech clinician, speech and language clinician. She's ASHA certified and LSVT Loud certified. She's also the Chief Clinical Officer and a faculty trainer for LSVT Global. And she comes to you from Colorado. My name is Beth Marcoux. I'm a physical therapist. I'm LSVT Big certified. And for the past several years, my clinical focus has been on the treatment of patients with Parkinson's disease, and I come to you from Alton, New Hampshire. All of the LSVT faculty have both financial and non-financial relationships with LSVT Global. Those non-financial relationships include a preference for LSVT Big and LSVT Loud as treatment techniques. The financial relationships include that Ms. Halpern is an employee of LSVT Global and receives lecture honorarium and travel reimbursement. Dr. Marcoux receives consulting fees, lecture honorarium, and travel reimbursement from LSVT Global. The learning objectives for this afternoon are that by the conclusion of this webinar, we hope that participants will be able to describe the typical motor and non-motor symptoms associated with Parkinson's disease, explain how the non-motor symptoms may affect movement, speech, and communication, and finally describe how LSVT Loud and LSVT Big address the cognitive, sensory, and neuropsychological deficits to promote improved speech and motor function. Parkinson's disease affects about 1 million people in the United States and about 4 to 6 million people worldwide. About 85% of those with Parkinson's disease have what's called idiopathic Parkinson's, meaning that there is no known cause. The most common characteristics of the disease are bradykinesia, or slowness of movement, and hypokinesia, which is small movements. While it's most recognized as a motor disease, there are many non-motor symptoms as well, and these are the focus of this webinar. As I just said, there are many non-motor symptoms associated with Parkinson's, but what if there weren't any? What if Parkinson's was only a motor disorder? Well, if that was the case, then motor output, in particular endurance and balance, as well as vocal loudness, articulation, and speech intelligibility, would improve quite easily with therapy and maintain with less effort over time. If it was only a motor disorder, there would be no need to convince patients to move bigger or to speak louder, and there would be no need for calibration training. If it was only a motor disorder, there would be no need for high frequency of treatment and high repetition. And patients would easily pick up on new exercises and new concepts, and there would be no need to teach them and retrain them in dual tasking and multitasking. So what's the origin of symptoms in Parkinson's disease? Well, the classic pathological findings in Parkinson's disease are the loss of pigmented neurons in a section of the brain called the substantia nigra pars compacta. On this slide, you can see the slices of the midbrain. On the top, you see the black area, which is the substantia nigra. And on the bottom, you can see the same area is depigmented. That's symptomatic of someone with Parkinson's disease, and it's the main basis for idiopathic Parkinson's. The interesting thing about this is that by diagnosis, patients have lost 50% to 60% of those cells, those dopamine cells that provide essential function. In addition, they've lost 70 to 80% of the dopaminergic terminals that connect those cells to other parts of the brain and the body. And these losses occur 5 to 6 years before diagnosis is made. You can also see that the basal ganglia have three primary circuits, and they have clinical implications. The overall organization of the basal ganglia is 3 separate recurrent loops that connect one part of the brain to another. The first part is the motor area. The second part deals with cognition, and the third with emotion. And all those 3 are extremely important in function. So according to this organization, the basal ganglia impact the motor functions, the working memory, attention, reward-related behavior, motor planning, body awareness, and selection and learning. Initially, it was thought that the basal ganglia dealt only with motor learning, but now we're aware that it impacts cognition and emotion as well. The bradykinesia, that smallness of movement, and hypokinesia, that slowness of movement, are the motor symptoms that we must address in LSVT. However, the treatment approach takes into consideration the non-motor symptoms as well, which are characterized by sensory processing problems, decreased cognition, and emotional processing disorders. It's these non-motor symptoms that can significantly impact treatment and the maintenance of outcomes. Many years before the onset of the motor symptoms of Parkinson's disease, patients will begin to experience these non-motor symptoms. One of the first of these is the loss or reduction in the sense of smell and GI problems such as constipation. Frequently, patients will experience depression and anxiety, as well as sleep disturbances, not being able to get into that deep sleep or REM cycle, so that they often end up being highly fatigued. As noted, many of these non-motor symptoms appear years before the classic motor symptoms do. So why is it important to understand the non-motor symptoms? Well, for people with Parkinson's disease, for their spouses, for families and caregivers, there are many times they're not aware that these invisible non-motor symptoms of Parkinson's can make it difficult to understand things like, why don't I have the energy that I used to have? Why do I lack motivation to participate in activities that I usually enjoy? And why do my movements and speech feel normal to me when others say I'm walking slower or speaking more softly? This next slide is an overview of the non-motor symptoms in Parkinson's, and you can see that there are many of them. Some I've already talked about. Depression, loss of higher cognitive functions, dementia, the difficulties with blood pressure, bowel and bladder, sexual dysfunction, the sensory changes that patients talk about, the sleep disorders, the anxiety and apathy, and finally some psychosis and hallucinations. We're going to talk about each of those. About 50% of patients with Parkinson's disease will experience depression, and it may contribute to dementia. They experience a loss of joy in interacting with others and feelings of isolation and loss of self-efficacy or belief in their own ability to do things. About 40% will experience high levels of anxiety, where they'll be fearful to do anything, and about 30% will have dementia. This rate of dementia is increased 4 to 6 times as compared to people without Parkinson's disease. Apathy is another thing that patients will have, about 40% of those without dementia, and it can be predictive of patients developing dementia. What are the consequences of these emotional or motivational deficits? Well, patients will display reduced vigor. They won't have the energy to do things that they typically always have. They'll implicitly choose to move smaller, use smaller and slower movements, and a softer voice. There'll be a loss of self-efficacy. That's that belief in their ability to do things. They will automatically default to lower energy despite having the ability to use more energy and to be more energetic. And they'll experience a perception of this cost-reward mismatch. So they don't understand that it takes more energy in order to achieve a greater movement or greater output of energy. And they'll display a decreased desire to start or participate in conversations or activities and experience a loss of joy in interacting. But LSVT programs can address this disorder of mismatch that's between perceived and actual output. And so by retraining their perception of what's normal, they'll be able to put the energy out that they need in order to make that louder voice and to have those larger movements. So they also experience significant cognitive changes. So loss of executive functioning. They have difficulty identifying a problem. They may repeat the same thing over and over and not be able to figure out why it's not working. They have difficulty planning a course of action and initiating an action. If I was to ask you to get out of a chair and you don't have Parkinson's, you would normally move to the front of the chair, lean forward, and stand up. But patients with Parkinson's disease, because of these decreased executive functioning, aren't able to self-initiate and to make that movement. They have difficulty evaluating how well they're doing. They experience bradyphrenia, which is called slower thinking, and they have decreased attention. They have difficulty sustaining attention or shifting it. So if they're working on a project and you come by and ask them to do something else, they have difficulty shifting to that other activity. They have increased distractibility. So working in an environment where there are many things going on is confusing for them. And again, that decreased ability to concentrate. They have difficulty with short-term memory retrieval. They can't remember what they did or what they had for lunch. They have decreased ability to multitask. Most of us can carry a basket of laundry up and down a flight of stairs and at the same time begin to think about a list of things we might need at the grocery store. But for patients with decreased executive functioning and cognitive changes, they're not able to do that. They have decreased ability to organize things, to set, shift, and to internally cue. The loss of function, of higher cognitive function, results in slower thinking and slower movements, and decreased response time to questions and movements. So if you ask them to change direction, no, turn to the right, it takes them a minute to recognize that they need to make that turn to the right-hand side or to respond to a question that you might have asked. Patients are often frustrated when people don't wait for them to respond or try to do things for them. Again, because dual tasking and motor planning are much more difficult for them. The step involved in motor planning for daily activities is very challenging for them. In addition to these motor challenges, they experience a lot of language challenges. They have delayed word retrieval, difficulty shifting communication topics, difficulty in initiating and expanding upon language, and some cognitive communicative difficulties. Difficulties with internal cueing is also a big problem for patients with Parkinson's. Again, if I was to ask you to rise from a chair, you would first scoot yourself forward, you would shift your body weight forward, and then you would stand and rise. All those things are done internally. You're cueing yourself to make those movements because you know that's what has to happen in order to stand upright. But patients with Parkinson's disease have a disruption in that internal cue or trigger for movements. So they don't self-initiate because they have this impaired go signal that comes from a loss of the dopaminergic cells in the basal ganglia. Patients with Parkinson also experience a lot of pain, and there are two different kinds of pain. There's the nociceptive pain, which is experienced by 40 to up to 90% of patients. These are the typical musculoskeletal problems that come from having that abnormal posture, the rigidity in their the rigidity in their extremities. They also have some visceral pain from constipation. And then they have neuropathic pain, which is like a radicular pain that is maybe due to disc damage, due to the kyphosis and the falls that they're experiencing. In addition, they also have a central Parkinson's pain that's directly related to Parkinson's disease. It's somewhat rare, but can occur in up to 10% of patients. And it's often described by them as a burning, cramping sensation, commonly occurring on the side of the body that's most impacted by their Parkinson's disease. And pain is frequently an under-recognized and often inadequately managed symptom for these clients. So it's something that you should pay attention to and bring to the attention of your healthcare providers. Patients with Parkinson's disease also have reduced kinesthetic awareness. That means that they're not always aware of where their limbs are in space. And so this results in decreased amplitude of gross and fine motor movements. So they would have difficulty walking, as well as difficulty with smaller movements, like buttoning buttons or zipping a jacket. They often tend to deny or under-recognize the reduction in the amplitude of their movement and the changes in their posture or their softer voice. They think other people are walking and leaving them in the dust, and they think other people have a hearing loss. They don't recognize that they have that small movement and that soft voice. And they deny the reduction in the amplitude or size of their movements. When we stimulate them to increase the amplitude of movement for voice or speech or change in posture, they'll often say, I feel like I'm moving too big or that I'm talking too loud. All these behaviors confirm that major sensory issue that underlines the motor problems in these patients. Other non-motor symptoms which impact mobility include the urinary frequency, having to go to the bathroom very often, incontinence, that loss of bowel and bladder control, and nocturia, which is the need to go to the bathroom several times during the night. This, coupled with their difficulty in getting out of bed and rushing to the bathroom to get there in time, can often result in falls. Patients with Parkinson's disease also experience orthostatic hypotension. That's when your blood pressure drops when you change positions rapidly. It's often due to the medications that they take. Because it happens and because of the resultant falls that come from getting up too quickly, they develop this fear of activity and so tend to withdraw and not do the things that they can and have been doing in the past. Drooling is another problem for patients with Parkinson's disease, and when they begin to drool, they begin to withdraw from society and don't participate in the activities that they typically have enjoyed. Again, apathy, we talked about before, that's that low motivation to be active and to be socially involved. And again, the sleep disturbances, they don't ever get into that deep REM cycle, so they're often fatigued and have a lot of low energy and all the issues that come with it. In addition, they can experience hallucinations and delusions, and that leads to fear and avoidance of participation, arguments with spouses and family, and many behavioral changes. So you can see that these non-motor symptoms significantly impact a patient's quality of life. So in summary, I'll just talk to you about how those non-motor symptoms affect movement and voice and speech. Those sensory motor deficits result in impaired sensory processing. They don't know where their limbs are. They don't realize how small their movements are because of that sensory motor mismatch. They have reduced activation for internally generated movements, and so that all combined results in slower, smaller movements. They have the deficits in cognitive and executive functioning and attentional deficits. Those result in inadequate preparation for movements, difficulty changing strategies quickly, inability to divide their attention between two tasks, adapting to environmental conditions. And finally, those emotional or motivational deficits. They have reduced vigor, and they choose smaller, slower movements because they have that loss of self-efficacy. they have decreased, they've defaulted to a low energy despite greater capacity, and they have that perceptual cost-reward mismatch. So why does it matter? Why do these non-motor symptoms matter? They matter because they're all barriers to better function. They're part of the reason that high intensity, high frequency of visits and repetition are needed in treatment programs to improve function. By not properly integrating treatment of the non-motor symptoms, treatment of the motor symptoms will fail, or the results will be short-lived. So I'm now going to turn it over to my colleague, Angela, so she can talk to you about how the LSVT programs impact the non-motor symptoms.
Great. Thanks so much, Beth, for that wonderful explanation of those non-motor symptoms. And as Beth said, we just really feel that this webinar is important for education. I know when I'm talking to individuals with Parkinson's disease and their families, many times these non-motor symptoms are things that people have never heard about before. And so once you hear about and learn about these, it can really help things to make a lot more sense of what might be going on with the Parkinson's disease. Next slide, please. So when we think about LSVT programs, they're administered in an intensive manner to challenge the impaired system. So we're really looking at, in Parkinson's disease, this decreased amplitude across the system, and we're working to increase that amplitude. So the techniques are specific to Parkinson's disease. So the bradykinesia, slowness of movement, hypokinesia, reduced amplitude of movement, and this kinesthetic awareness or sensory mismatch that Beth introduced that we'll talk about in a little more detail, as well as some of these subtle neuropsychological deficits. So one of the distinguishing features of the LSVT programs is that they were designed to intentionally and specifically address these non-motor symptoms. And that's unique when we think about these LSVT programs, because many other exercise and therapy programs that are out there for physical therapy, speech therapy, don't recognize this issue with kinesthetic awareness and some of these other non-motor issues, which can be a barrier to calibration. And by calibration, we mean helping people to recognize what is normal movement, what is a normal loudness for voice and speech. And if that's not addressed in treatment, people can do all the great exercising that they want and get you to a certain level of function, but if that's not addressed, those behaviors will not carry over outside of the treatment room. Next slide, please. So LSVT includes key treatment principles that drive activity-dependent neuroplasticity. So whenever you are looking at a physical therapy or a speech therapy that you might want to participate in, it's important to understand why does this specific treatment work. So in addition to looking at what's the research data behind it, what's the mode of operation that's making these changes? And we see now a lot of principles derived from animal models that are getting this translation to human models that show us what's important for making change in the brain. And that's when we talk about neuroplasticity, we're just talking about the brain's ability to change. So we see that intensity is important. And we talk about intensity with LSVT programs. They're intensive both within the time they're delivered, how the therapist pushes the individuals in those treatment programs, but also they're intensive because they're delivered 4 times a week for 4 weeks in 1 month. And that's different. Sometimes people will say to me, well, why do I need to do this intensive treatment? I'd rather just go 1 time a week or 2 times a week. But what we see is that intensive treatment is crucial if we want to make long-lasting improvements in Parkinson's disease that carry over. It's required for that maximal plasticity or change. And then that change gets solidified with the next principle, which is repetition. And in the treatment exercises, it's not a boring repetition. You're not just repeating to repeat, but rather your therapist is always working to shape and model and push and drive so that it's helping you get to that normal loudness or normal movement on your own. And as a therapist, I'm constantly thinking, how can I challenge and push my patients so they can get the maximum benefit out of the motor exercise that we're doing. And then we look at the treatments are complex, and this is important when we say complexity, not complexity in difficulty, but complexity in what they're targeting. And so the therapist is looking at and designing the tasks very specifically to start simple and gradually get more complex across the weeks of treatment to enhance learning and carryover and maintenance. And one of the other things that's really unique about these treatments is saliency. So therapists really target what do the people they're working with, what are their functional goals for improvement, and all the treatment activities are designed around what's personal and important and salient to that person to get long-lasting function outside of the treatment room. And then the last principle is specificity. And so with LSVT programs, we're training to the specific issues that people with Parkinson's see. So this decreased amplitude in the motor speech system, but also bombarding the sensory system to deal with some of these non-motor symptoms as well. Next slide, please. When we look at treatments, it's important that the team is working together. So we really see this model of LSVT, physical, occupational, and speech therapists working together to address these non-motor symptoms and communicating as a team to have the best outcome of improved quality of life for the people we're working with. Next slide, please. So the LSVT protocols have been based on over 25 years of federally funded research and clinical experience. And if you're not familiar with the treatments, LSVT Loud is a speech therapy that's delivered by an LSVT Loud certified speech language pathologist. And LSVT Big is a physical occupational therapy that's delivered by LSVT Big certified physical or occupational therapist. So any therapist delivering these treatments have gone to a 2-day training course because the goal is that we have treatment protocols that work. And we want to make sure whether someone's receiving the treatment in Japan or Germany or the United States, that all the therapies are being delivered in the same way so people across the world can benefit from those. Next slide. So the protocols are structured, and it is a specific protocol that's based on research evidence. However, the therapists work to individualize that protocol for each person. So within the specific protocol, personalized goals are selected, personalized activities to really target the specific goals of each individual. And as we were saying, it adheres to principles of motor learning and activity-dependent neuroplasticity, incorporating that great intensity and challenge that is needed to make change. Next slide. So LSVT Loud and LSVT Big are separate protocols. Sometimes people say, well, can I do them both in 1 hour? No, you need that hour of the speech therapy and the hour of the physical or occupational therapy each day. So each protocol is 4 times a week for 4 weeks, 1-hour sessions in 1 month. And then there is daily homework practice and carryover. It doesn't take a lot of time, but we see that it's essential for people to learn to do the same activities they're doing with the therapist outside of the treatment room so that they can continue to have success once treatment's over and have a routine well established. Next slide. So the goal of these programs is for people to use a louder voice following LSVT Loud and bigger movements following LSVT Big habitually in everyday living. So the goal for us as therapists is that that louder voice or the bigger movements will last over time. And so we really work to help our patients learn how to internalize and learn to achieve this on their own. Next slide. Oh, we're there. Okay. So let's talk about some of the emotional changes that and how those can impact treatments and how LSVT programs look at this to enable success. So Beth introduced at the beginning that some people with Parkinson's may notice apathy or this lack of motivation. And so in the treatment sessions, therapists are very encouraging, and there's a lot of energy, and we see with that encouragement and that energy, that we get this increased participation and motivation from our patients. So patients may come in and not be too sure about the programs, and maybe not have that a lot of motivation, but once they get in and they start to see the changes that can happen with voice or speech or movement, then we can really see a change in that vigor and in that motivation and independence to want to continue to participate. As I mentioned before, goals are personalized for each person, because it's wonderful if my patients can work with me and get this wonderful loud voice in my treatment room, but I'm not their real world. So I'm constantly working to make sure they get that voice in their real world outside of the treatment room. Likewise, it's great if Beth can get someone to have big movements while she's working with them, but if that doesn't translate to, I can now get in and out of the car better, or I can walk further, then that's not their real world. So that's what she's working towards, getting that translation into the real world. So looking at how we can, through success with these treatments, we can see this change and increase in the motivation and directly impact and change some of those emotional issues. And as therapists, understanding these non-motor symptoms, your therapists understand that some days, yeah, you are going to be more tired. You didn't sleep last night. You might be having a bad day. But then it's the therapist's job to show you that, you know what, you can do this even when you don't feel your best. And that can be really empowering. Next slide. So through these therapies, we work to enhance self-efficacy. So with that self-efficacy, it's that individuals see that they can achieve success, and then this in turn results in this enhanced self-motivation and confidence to want to then continue to succeed and achieve more independently. So as therapists, our guiding principle is that we always want to empower our patients that we're working with and show them, yes, you can do this. You can do things that you have not done for years. I had a lady I worked with once, and after she was able to get this nice normal loudness, voice and speech, and be able to talk and communicate, she said that she saw through the therapies that she thought there were a lot of things with Parkinson's that before therapy that she hadn't been able to control. But she saw that her voice was something that she could control. And then she told me that she had declared war on Parkinson's disease, and she could see that there were aspects of it that she can control. And that's our goal as therapists, to see, yes, you can have more control over your movement. You can have more control over voice and speech. Next slide. So when we think about some of these subtle neuropsychological changes and thinking that can happen, how can LSVT programs enable success? One of the things with the LSVT programs is we have a single focus in treatment. So if you're working with a speech therapist, that single focus is think loud, and your therapist is working to get you to normal loudness. If you're working with the physical occupational therapist, the single focus in treatment is think big. So working to get those bigger movements to normal levels. Now we'll talk in a bit about this more, but to our patients that we work with, when we say think loud, to the patient it feels loud or it feels big, but there's a sensory mismatch in Parkinson's disease. So what might feel too loud or too big to our patients that we're working with is really normal loudness or normal movement. And so we work a lot on helping our patients to see on their own how to target that normal loudness level, normal movement. The treatments are repetitive, and this is essential for making change. And we talked about that not repeating just to repeat, but by always being challenged through that treatment session. And then therapists do a lot of modeling. We found this is much more effective than lengthy explanations. So rather than me saying to a patient, sit up straight, take a deep breath, open your mouth, over-articulate, now do that loud, which is too much for any of us to remember, I can simply, through my model, show all those behaviors that I want, and then say, think loud with that single focus, and it's much more efficient for my patients to be able to be successful and achieve. Likewise, Beth might, rather than saying, scoot to the edge of your chair, plant your feet like this, lean forward, now do this, do that. She can just say, think big, and model that big behavior that she wants of coming from sit to stand from a chair. So it's a much more efficient and effective way for treatment delivery. Also, as therapists, if people are having some of these subtle neuropsychological changes and problems with distractibility, we can alter the treatment environment if it's necessary. So going to places that aren't as distracting, that are a little more private, that don't have as much background noise going on. And then because our therapies gradually increase in complexity, starting at a simple level week 1, then gradually increasing in complexity across the weeks, we're able to really enable success every step of the way for our patients, and they don't feel like they're just thrown into the end of I have to walk big all the time and talk big all the time in all environments. We help our patients get there every step of the way. Next slide. So when we also look at these changes in thinking and how LSVT programs enable success, we like to include tasks that are more challenging. So sometimes I'll have patients tell me, I can stay loud when it's a quiet environment and I understand the communication situation, but it's difficult for me to stay loud when there's a lot of background noise or when it's an unexpected communication context and I don't know how to approach what I'm supposed to be saying. So I will actually find activities to work on with my patient to help them see how to handle those challenging environments. So maybe I'll turn on some background noise and have someone use impromptu speeches while staying loud so that we can target this issue of thinking and having to remember to be loud at the same time. Or perhaps talking loud while pulling money out of a wallet like you would have to do at a store. Or if Beth is working with someone, she might have them practice walking with big movements while having to talk or think about something else at the same time, because that's real world. Practicing big movements, maybe someone likes to play cards while you're having to sort or shuffle a deck of cards while explaining a game. So this type of multitasking to help prepare our patients for what they might experience outside of that treatment room. Next slide, please. So when we think of these sensory kinesthetic changes, how can LSVT programs enable success with these? So we are re-educating that sensory motor system. Our goal is to retrain this internal cue for increased amplitude. So if that's increased amplitude for bigger movement, increased amplitude for louder voice and speech, with our ultimate goal being that by the end of treatment, individuals are able to achieve this normal loudness and normal movement on their own. So I tell my patients that my goal is that you don't need me. I want to become not needed to you. So I'm always pushing them so that they can achieve the desired behavior on their own and learn how to feel internally what's the effort and loudness I need to use to be at normal loudness without me giving that feedback. Likewise, in LSVT Big, the therapists are constantly training and having people give feedback on, was that how you needed to move? Was that the bigness you needed to use? So that people can learn to target that on their own and be successful. Next slide. So what we can see initially with patients with Parkinson's disease is what we call this performance. So session 1, people will come in, Beth might ask them to move big, I'll ask them to talk loud, we give examples, and people can do this because we see this immediate change in behavior with this performance, but it's a performance to the therapist's external cues. And then when people walk out of the treatment room, they're back to the small amplitude, small movement, small voice. Rather, what we want to change in treatment and throughout our therapies, next slide, is by bombarding that sensory system and retraining sensory calibration that our patients learn independently how to internally cue for this new normal loudness voice or for bigger movements, and so that they can and will carry that over independently outside of the treatment room. Next slide, please. So some ways we enable and target these kinesthetic issues are providing consistent feedback to our patients. Feel the effort, hear the loudness. That's the effort and loudness I want you to use when you talk to your friend at the ball game tonight. Or, that looked great. That's the amount of effort you need to give to clear your foot as you get into the car every single time. And then starting to ask for that feedback from our patients. Was that the loudness you needed to use? Was that the movement? So they can internally cue that on their own. Next slide. So how can care partners help with this? As Beth and I both introduced, we feel that it's so important for care partners to understand these non-motor symptoms, to have some insight into some of the difficulties those that you care for may be experiencing. So just that understanding and encouragement of, if someone seems like they don't want to do something, it's not necessarily because people are being lazy or stubborn. Thinking back to the difficulties with initiation, the difficulties with apathy and those sorts of things. And I like to tell my patients, imagine, the spouses or caregivers of my patients, that imagine if I asked you to go to the deli today and say at the deli counter, I want a pound of roast beef, in a voice that feels way too loud. Well, that's what it feels like to the individuals, to your spouse or care partner, every time we ask them to get to normal loudness. So having some empathy about that. Or for movement, imagine if you felt like your feet were stuck in the mud every time you went to take a step. So the amount of effort that that takes. So just acknowledging the effort of your loved one and then motivating them with positive feedback when you do see them talking louder, moving bigger. Next slide. And then once they finish treatment programs, continuing to motivate and help them with home exercise programs in an encouraging way. Maybe you can even do the exercises together. And so we have lots of tools following the LSVT programs. We say keep in continual touch with your therapist for periodic tune-up sessions. These are exercise programs, so you have to continue to exercise to continue to keep the benefits, just like any exercise program. And then there are DVDs available to help motivate for practice. And then we have just recently this year launched what we're calling Big for Life and Loud for Life groups that we're very excited about. And these are groups of people who have graduated from LSVT Big or graduated from LSVT Loud, and they meet together weekly to practice their exercises in a fun, encouraging, motivating environment with other graduates. So stay tuned for more information about those groups that might be coming to your area soon. And then as care partners, just understanding that reluctance to participate is not stubbornness, but it can be impacted by these non-motor symptoms. So empowering your loved ones, showing them how they can. Next slide. And you have the availability of handouts from this presentation, and so these provide you with some links for further education if you want even more information on some of these non-motor symptoms. Next slide. So in summary, we see that people with Parkinson's have these sensory deficits, and they must be addressed if we want to see this long-term improvement in speech, movement, and quality of life. And that people can improve and make that long-lasting improvement, and these LSVT programs can help. So we really appreciate the time that you have spent with us. We feel this is such an important topic for people with Parkinson's and care partners to know and understand, so that there aren't misunderstandings about these non-motor symptoms. Next slide. And here's some further learning opportunities for you. We do offer these live webinars about once a month, and then we also, this webinar is being recorded. The previous webinars have been recorded, so then they're on demand for you at any time. And there's information about, you can find those on our website, going to the website under webinars. And then we also had talked about some of the homework helper, and then we always have experts available for questions as well. So I'm going to turn it back over to Beth now, and she can review how you can ask your questions, and we'll be happy to take any questions that you might have.
Thanks, Angela, for a wonderful presentation on the LSVT programs. Now, if you have any questions that you want to ask, there are 3 options for that. First, you can type it into the question box on your control panel, and I can read it aloud for you. The second is you can raise your hand. You'll see a hand icon on your control panel. When you do that, I will click on it and call out your first and last names. Your mic will be unmuted, and then you can ask the question aloud. Or the third way is just to email the question to info@lsvtglobal.com if you think of questions later in the webinar or after days from now when you have something comes up as you're riding in the car. So just give me a moment. I'm going to see if I can see if there are any questions. There is one question, Dean Prescott. If you want to ask that question, I can go ahead and unmute your microphone now. Hang on, I just got to get to you. Okay. Dean, I'm having a little difficulty unmuting your microphone, so if you could type that question in, that would be great, and I'll go ahead and read it. How do I get my insurance to cover the program? Angela, you can go ahead and take this one.
So insurances across the country, whether you have Medicare or other types of private insurance, we have thousands of trained clinicians all across the country who are getting the programs reimbursed for their patients. So if for some reason you are talking to a therapist and they're unsure about reimbursement, or they feel like they need some assistance with reimbursement, we actually offer full-length webinars for our certified clinicians on here's all the in and outs of reimbursement, documentation, and so we're happy to help your therapist to enable success with that. So if it's just a general question of will it cover it, we do see nationally that if you're have an insurance that covers physical, occupational, and speech therapies, many times it will be covered. And if your particular therapist is having trouble getting that reimbursement, feel free to have them connect us, and we're happy to help with that as well.
Thank you, Angela. That was great. I see we have another question from, let's see, someone had their hand up and now the hand's disappeared. That hand disappeared, so I don't see the question anymore. Are there any other questions that people might have? Or if whoever had that question wants to type it in? Nope, there don't seem to be any other questions. Okay, thank you so much for your attendance. Angela, that was it gave us some wonderful information on LSVT big programs. We want to thank you for joining us today, and thank you to Angela for presenting such helpful information. We would love to hear from you. So email us with any additional questions or comments or ideas you might have for future webinars. We thank you very much for your attendance and hope you have a wonderful day.
Thank you.
Bye now.